Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring advanced back pain management and robotic advances in spinal surgery. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare, education and research. Today I'm joined by two guests. My first is Associate Professor Tillman Boesel. He is a pain management specialist who practices at Macquarie University Hospital and Macquarie Neurosurgery and Spine. He is a Clinical Associate Professor at Macquarie University's Faculty of Medicine, Health and Human Sciences. Associate Professor Boesel, can you walk us through the classification of different types of back pain and why it's crucial for effective management?
There are essentially three types of back pain that we contend with in clinical practice. The first is back pain with a radicular pattern, which is tied into nerve root dysfunction of some type. So these people have fairly classical neurogenic pain, which is lancinating, burning, stinging, electric, that radiates from the lower back into the lower limb, usually below the knee, although it can be above the knee if the L2 or L3 myotomes and dermatomes are involved. There is claudicant low back pain, which again is a neurogenic syndrome where people get exercise-induced back pain radiating into the lower limbs, which comes on after a predictable walking distance and is relieved by leaning forward. This really relates to spinal canal stenosis of some type. And the final type, which we deal with a lot, which represents about 70 to 80% of the back pain population, is what's known as non-specific back pain. And that is a clinical syndrome that has a whole bunch of causes, usually multiple of which are overlaid upon each other, including facet joint arthrosis, discovertebral pain, myofascial pain arising from ligaments or muscles, or a more central cause with lots of central sensitization. This type of pain is usually localized to the lumbosacral region, and it can radiate, but usually not much beyond the bottom end of the buttocks or the top of the thighs posteriorly.
What are some of the most common red flags that GPs and specialists should be aware of in chronic back pain cases?
So what we're really looking at is conditions that require urgent treatment. So we're thinking about malignancy, infection, traumatic fracture. So patients who present with fever, night sweats, severe pain on lying flat that doesn't resolve, neurogenic features. So again, if you've got nerve root compression or of a significant degree or severe spinal canal stenosis, so the claudicant type, you may need surgical intervention. So patients that have got a significant radiculopathy in association with their pain, so with motor loss or dense sensory loss, or patients who've got a progressively reducing claudication distance when they're exercising, who may or may not have bowel or bladder involvement as well. So they're the red flags. I think it's important to talk about yellow flags as well, which are the flags that indicate a risk of chronicity. So the patient that we classically think of here is a person who presents with a very significant amount of distress as part of their presentation. Teary, depressed, very anxious. Often there's a compensation element involved, workers' compensation, where there's a high risk of chronicification due to central factors. Patients on opioids obviously fit into this category too. Generally speaking, it can be picked up on psychometric measures, so the DAS-21 or things like the hospital anxiety and depression score, HADS, which some people use, or the Orebro brief inventory, which is probably the most sensitive. And certainly if you have an Orebro score of greater than 50 out of 100, you're highly likely to go on and develop chronicity.
What new pain management modalities have shown promise for patients with chronic back pain, especially those unresponsive to traditional therapies?
In terms of the approach that a pain medicine physician would use, the new modalities are really in the interventional domain. So in the United States, they've developed a technique called basivertebral nerve ablation. So this is specifically helpful for patients with discogenic pain who have modic changes, so inflammatory changes in the bone above or below the disc. And it involves the placement of a radiofrequency lesioning cannula into the vertebral body and then lesioning the basivertebral nerve, which sits inside the vertebra close to the end plates, for about 16 minutes. Now, this treatment has been shown to have durable benefits out to 2 years in their randomized controlled trial. with an average pain reduction of about 4 out of 10, which is clinically meaningful, and about a 25% drop in the Oswestry disability score. So that's pretty significant. Unfortunately, the technique is currently not available in Australia because the hardware involved hasn't been licensed by the TGA, although we suspect there's going to be entry into our market at some point in the coming year or two. So that's a very exciting treatment because discovertebral pain has traditionally been very difficult to treat with non-surgical methods. And it's been termed by some of my colleagues as a graveyard for pain physicians. So I think that's a very exciting option. The other new modalities are obviously in the neuromodulation sphere. So there's a number of neurostimulation devices which are showing considerable promise. And there's been some new data that would suggest that there may be benefit with paresthesia-free stimulation for non-specific low back pain. So there's one study that came out late last year about the Burst DR system by Abbott, which suggested around about 50% pain reduction in non-specific back pain over the long term. So those options have traditionally always been used, but the scientific evidence was not clear until emerging studies in the last year or two.
How do you see advancements in pain management contributing to improved quality of life for patients?
I think poor pain control is one of the major factors in low quality of life. And you'll be aware that 20% of the population suffers pain on a daily basis, and probably 1 in 10 of those people, so around about 2% of the population, suffer sufficiently to probably warrant a pain medicine physician involvement. Quality of life really revolves around symptom control, but it also revolves around function. So there's a pretty tight correlation between improved symptom control and rehabilitation capacity. So people who've got poor symptom control don't get much out of physical therapies, for example. So if you reduce their pain via another mechanism, they're more likely to be able to rehabilitate. Obviously, the other quality of life factor is medication use. So patients who are on opioids and multiple other centrally acting medications often end up quite sedated and disengaged from life. So that's a pretty significant quality of life factor. So with improved pain control, we would expect to see improvements in quality of life, which would be potentially quite significant. And as I've indicated, there's a variety of different strategies that we've got for that. Most of them are time-honoured and older, such as lumbar radiofrequency neurotomy for facet joint disease. And then obviously some of the non-interventional therapies, such as mindfulness meditation, self-management strategies, psychoeducational approaches, and things in that domain, which really fit into the sort of rehabilitative paradigm pain medicine physicians use.
Are there any recent innovations you're particularly excited about?
Yeah, look, there's a new type of neurostimulator called a multifidus activation stimulator. So the multifidus muscle is an involuntary slow twitch fiber muscle that sits in the paravertebral gutters in the lumbar region and helps smooth out and regulate movement, particularly flexion and extension of the spine. That muscle is very rich in muscle spindles, so it's one of the main sensory organs for the brain in terms of determining spinal posture. Now, there's good evidence that muscle deteriorates quite rapidly if you've got a spinal pathology, such as an acute intervertebral disc prolapse or spinal arthritis or something like that. And as the muscle deteriorates, you lose smooth motor control, and then you get excessive overloading of the pathological elements and worsening pain. So this device is implanted with stimulation wires over the main innervation of the multifidus, which is the L2-3 medial branch nerve. So it's an extra spinal or extra axial implant, which is quite safe. And the patient activates it for 30 minutes twice a day, and that activates the muscles. So they get rhythmic contraction, which is like a pattern of exercise. And it's specifically designed for patients who've failed physical therapies. Now, the study in this regard has shown very positive outcomes out to 5 years now, where we're seeing 70% pain reduction and about 50% reduction in the Oswestry disability score, which is sustained, so the patients don't fall into failure. The other thing that's very interesting is that very few of these patients have then gone on to have secondary surgeries, which would suggest that restoring multifidus muscle function perhaps protects those pathological elements from progressive deterioration. So it's a very exciting device. I've put in 25 of them so far, and my outcomes are pretty consistent with the study. So about 70% of patients have shown a durable benefit out to 2 years in my hands. So I'm very excited about that. And it's a new paradigm for thinking about low back pain.
My next guest, Dr Matthew Tait, is a neurosurgeon who specialises in spinal disorders and cerebrovascular diseases. He practices at Macquarie University Hospital and Macquarie Neurosurgery and Spine. He is a senior lecturer at Macquarie University's Faculty of Medicine, Health and Human Sciences. Can you tell us about pre-surgery planning in the surgical process and why imaging is so important?
So at the initial planning stage, we obviously meet with patients and try to establish what their symptoms are, how severe they are, and we can tell a lot about what's going on by the location of someone's pain, particularly their leg pain. Each of the nerves in the back do something slightly different, and by establishing what the location of the pain is in the leg, we can try and work out exactly which nerves are involved in the case of a patient with leg pain. We also need to know how severe are the symptoms, how much are they affecting a patient's quality of life, how much are they impacting on day-to-day activities, and also is the patient well enough to undergo what can be quite a large operation. So we need to know all about their previous medical history as well. We need to know what treatment they've had up to date, and whether they've exhausted all the conservative measures. Have they tried painkillers? Have they tried pain specialist techniques? Have they tried physiotherapy, weight loss, lifestyle changes? If all of those things have been tried and haven't been effective, then we can start to think about surgery. And the main aim of the imaging in the workup is to try and establish exactly where the pain is coming from in terms of which parts of the spine are causing the pain. Very often patients have a CT scan which has been organised by their GP, but really the best two scans, and the CT does give us a good idea of it's a good screening test to look for other pathologies, but the main two tests that we need to have in order to work up a patient are an MRI scan and the bone scan. The MRI scan is a very good way of looking to see where there are trapped nerves, and those are what causes the leg pain. So the trapped nerves causing the leg pain we see very clearly on the MRI scan. The bone scan shows us hot spots within the spine. It's a very clever test. We inject a weak radioactive tracer, and that tends to accumulate in parts of the spine which are painful because they're getting an extra blood supply, which is the body's way of trying to deal with the situation. So that shows us which discs potentially and which facet joints, which are the small joints at the back of the spine, are causing pain. The MRI scan gives us an indication of that, but just because something looks abnormal on an MRI scan doesn't mean it's necessarily painful. So in conjunction with the bone scan, we can try and really work out where the trapped nerves are that are causing the leg pain and where the painful parts of the spinal column, the facet joints, the discs and so on, are, which are causing the back pain. Some patients would benefit from a CT scan, particularly if they've had previous surgery, and that's to look for loose screws and to see whether the bones have united in the way that we hope that they will.
Can you explain how robotic-assisted surgery is changing the landscape of spine care and what benefits it offers to patients and surgeons?
Well, I've been using the Globus robot for over a year now, and coming up to 100 cases with that, and I found it fantastic. So the main advantages are what the robot actually does. It's a tool that we use, and it's a way to position screws. So it's only the part of the operation where we're putting the screws in at the moment that the robot is being used in my practice anyway. It does mean that the screw placement is faster and more accurate than it was when I was doing it without the robot, and it gives me greater confidence to put screws in unusual trajectories. So I had been doing cervical pedicle screws before, and I had been doing cortical trajectory screws in the lumbar spine before, but I think with the robot these are much quicker. I have a lot more confidence doing it, and I would put in larger screws which are more beneficial using that technique. And also it's easier to do operations with patients in slightly unusual positions. So the traditional way to do spine surgery is with the patient lying face down, but more and more we're doing these operations the patient's lying on their side, and certainly the robot helps with that. Because we can use different types of screws more commonly, it means that, for example, in the cervical spine, where previously we would be using lateral mass screws, if we use pedicle screws in the cervical spine, we can potentially fuse fewer levels, which is of an advantage to the patient because fewer levels of the spine will be immobilized, and that is less painful and preserves more range of movement. Also in the lumbar spine, where we're using medial cortical trajectory screws instead of pedicle screws, there's a lot less muscle exposure which needs to be done before putting the screw in. So that means the incision can be smaller. There's less damage to the muscle at the back of the spine, which means that the operation is quicker and there's less post-operative pain. The patients recover faster and go home sooner. A further advantage of using the robot is that you can really plan the positioning of the screws to a very fine degree, much more than I could have done before when I wasn't using a robot, to make sure, for example, if we have a long row of screws that all need to be connected using a rod, we can make sure that they're in a perfectly even line, which means that when I go to put the rod on, it's much easier to do that. There's a lot less stress on the spine when the rod is applied, and that part of the operation is also faster. So there are lots and lots of advantages.
In addition to robotics, what other medical innovations in neurosurgery are you currently implementing or looking forward to integrating at Macquarie University Hospital?
Well, the thing I'm working on at the moment is using navigation to put the cages in. So navigation is the system whereby we use scans during the operation, scans that have been taken beforehand, to work out where we are in the spine. And the cages are the spaces that get put in between the vertebral bodies where the disc used to be. So the main building blocks of the spine are separated by discs. And often in spinal surgery, we remove those discs and put a spacer in there. And in the past, we did that with X-ray guidance or even just by freehand. But now using navigation, we can get those spacers in much more accurately. And that's something that I'm working on at the moment. The navigation also allows us to clear out the disc space more accurately as well. There was always a risk of going through the front of the disc and damaging something in the abdomen. And with the navigated instruments, we can see exactly where we are in the disc space and get a really good clearance. And that may allow us to use new techniques as well, such as the prone lateral approach, which has distinct advantages for spinal operations. So that's something that I'm working on for the future.
How do you approach complex cases of back pain that have not responded to other treatments?
So I would take a careful history. I, of course, meet with the patient, take a careful history, do an examination, find out about all their other medical issues and find out just how much this is affecting them. Then we'd ask for some tests. The initial test would be the MRI scan to look for trapped nerves, to look for worn out discs and worn out facet joints. And then to order a bone scan. Same time, first line investigations would be an MRI scan and a bone scan. The bone scan to look for hot spots in the facet joints or discs. Also, we need to work out whether or not their back pain is coming from another cause. There are potentially other causes of back pain. But in the case where we have a person with a worn out back who's got severe back pain, those would be the first two investigations. Once we've established where the pain is coming from, the essential surgical technique for treating back pain is fusion. And the idea is that when there's a painful joint, immobilizing that joint so that it stops moving will stop it from hurting. And the main way to immobilize the joint is to encourage bone to grow between the two sides of the joint. So, for example, if you have a very painful disc, removing the disc, putting in a spacer, and then filling the rest of the disc space with bone chips should cause the bones either side of that spacer to heal together. And that's the fusion. So the fusion is actually something the patient does rather than the surgeon. Fusion is the two bones healing together. And once that's taken place, that joint should stop hurting.
With pain management playing such a critical role in neurosurgery, how do you work with pain specialists to create comprehensive care plans for your patients? And why is a multidisciplinary approach important?
I think this is vital. When I started in my practice, I was horrified by the amount of perioperative pain that a lot of patients have having spinal surgery experienced. And often this is because patients with back pain have been in pain for a long time. And they've been on painkillers for a long time, and they can develop tolerance to those painkillers. That means that a given dose of painkiller has less effect than it would have done when they first started taking them. And that tolerance can build up and up and up, and actually make it very hard for us to control patients' pain, which results from surgery. I think it's vital to have an integrated approach, not just between the pain specialists and the surgeons, but also with the anaesthetists as well. And the way we do this is that patients are seen by the pain specialist before the operation. They're managed in the perioperative period in the hospital by the same pain specialist, and that pain specialist makes a plan with the anaesthetist for correct control of pain. The things we do are we admit the patients early and stop all their opiate analgesia with cover of ketamine. So while they're on the ketamine, they have their pain controlled by the ketamine, but that's not an opiate drug. We can stop all of their opiate drugs, and even just a short period, 24, 48 hours, will reduce the tolerance and allow us to use opiates more effectively in the perioperative period. During the operation, we use minimally invasive techniques. We reduce the amount of muscle resection using techniques such as robotics and other minimally invasive techniques in the spine. And the anaesthetist will liaise with the pain specialist, and they will make a plan that will often include local anaesthetic blocks, which we're using more and more for perioperative pain management. Then after the operation, we have a streamlined approach whereby we make sure that the drugs are all drawn up in the ICU before the patient comes round, so that there's not a gap in analgesia provision while the patient's waking up. And then the patient is reviewed daily by the pain specialist to make sure that they're on the correct pain management regime. So the days when the surgeons used to manage the pain control in the perioperative period, I think, are sort of coming to an end.
Thank you to my special guests, Associate Professor Tillman Boesel and Dr Matthew Tait. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare, education and research. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.